Hello and welcome to the Wales Cancer Alliance breakfast briefing with Dr. Mark Taubert. This is the first in the series of briefings during the coronavirus pandemic. Mark is a consultant in palliative medicine working at the Velindre Cancer Centre, and to kick off the series, Mark discusses his experiences of clinical practice during the coronavirus pandemic. We hope you enjoy.
Communicators. Really, what I want to do today is just kind of see what I've noticed and then open up the discussion. Maybe I'll talk for 20-30 minutes or so, take you through some things that I use, and then you can say, well, Mark, actually, I've got something I find better, and I want to maybe learn from you today as well, because it's about mutual learning, I think. So without too much further ado, I'm going to share my screen now. Let's hope it works. Let's go to the PowerPoint. Let's see where it is. Share. There we go. I hope you can see that. And if my face is in the way speaking, then feel free to move it around the screen a little bit. That should work. So today I want to just talk about some of the difficult conversations and what's made them more difficult during COVID-19. I mean, one of the first observations is that I'm a palliative care consultant at Velindre Cancer Centre and at Llandoch Hospital as well. Everything has really changed. And I know some colleagues on this chat today as well. Everything has changed for them as well, significantly. So my clinic, outpatient clinic, probably gone from 2% phone in the past and 98% face-to-face consultations on a Thursday morning to exactly the opposite. Most of my consultations are now via video or phone consults in a very short space of time. Reason for that is, you know, people want to be safe. They don't want to come to hospitals. They've been very frightened of going to hospitals. And so that has been a means of communication. And if they do come to the hospital, you know, often this is sort of something that they would see. So not necessarily something that they would particularly choose. And I have seen a few people in the Velindre car park, which I would never have dreamed of doing before. But it was really for stuff that I felt, you know, a video consultation or a telephone consultation is not really good in this situation. I'm going to take this off now. It's getting a bit unpleasant. I wanted to see how long I could stand it for. But actually, I must say, even when I'm up on the wards, I mean, this is an easy mask, I would say. But some of the really tight masks are really tricky to keep on and sustain for a long period of time. So hello everyone, this is me. Yeah, I was not really quite prepared before all this started for bad news consultations via video or telephone. Actually, I've done DNA CPR discussions by telephone and by video consult. So people would have seen me like you are seeing me now and would have had a conversation about CPR or not for CPR and the ins and outs of that. You know, not really something I'd envisaged. And ceilings of treatment conversations as well. And actually talking to relatives, friends about the fact that their loved one has died. And I'd say I've not done that very often, not as often as some of the junior colleagues in Llandoch that I've worked with, for instance. And I was on the wards there quite recently and was working with some of the junior doctors, and everyone was wearing full masks and PPE and on the telephones and having to tell very close relatives that someone had just died over the telephone, where usually as a human being, you want to talk to them in a quiet room, you know, make sure they've got a cup of tea and there's someone else around, and that you can tell them personally, face to face. So really horrible and quite traumatic. I've found that, and I've had conversations with some of those junior doctors about it, and they said, well, it's just become the new normal. So, you know, some of the resilience there has been huge, but you do wonder what the fallout is, both for the relatives and the loved ones or those bereaved those family members, but also for the healthcare professionals, the nurses, the HCAs, and the doctors who sometimes have to make these phone calls. This is just a recent, fairly crazy example of communication. So this is me on the wards in Velindre, and there's a patient who can not speak a word of English, and I have to go in with the team, at a safe distance, full PPE. So this is outside the room. I haven't got my full kit on yet. I'm just setting up the language line computer so that the language line translator can come into the room as well, while I'm in my full PPE and trying to communicate with this individual about ceilings of treatment in a completely different language. I talked this through with my team and registrar at the time, and just how incredibly strange and bizarre what we've just done there. It worked out okay in the end, but just imagine it, talking to a bunch of masked people in a language that is not your own, talking to a screen with an Arabic interpreter on it from language line, and then talking about the end of your life. It isn't. It's really strange, really very strange. And communication has really upped its, the challenge of communication has upped its game a bit, certainly from what I'm concerned. And I'm first to admit, I've made quite a few errors along the way. And the last error was yesterday in terms of just kind of, the way you communicate and what you say when you use these new means of communication. So, really up for all of us who are interested in this topic, and charities like Macmillan, to really kind of step up and kind of say, okay, this is a new era of communication, and we need some new tools and some new guidance. And perhaps this talk is a very small kind of needs assessment of what we need to be doing, really. So very quickly, I cobbled together a 5-point checklist for this kind of thing. When you say using video consults or pick up the phone to someone, I know there's quite a few CNSs in the audience today, and I think for them this is quite important, because I think a lot of them are using telephone or video consult a lot more rather than always going into the houses of people. And in fact, I know some of the CNSs have been turned away from people's houses because people have been too scared to let healthcare professionals in, which is a new dimension. And I know some CNSs who've been talking to patients through the window, so they've been in the garden and the patients has been inside. So lots of new communication challenges there, I think. But yeah, so check your environment, really. That's a big one. So for instance, today, just sitting just over there from me is Jo, our secretary here, and she's there. She knows I'm on an important call, and so she's not going to be munching her crisps very loudly or eating her sandwich. And she knows if someone comes in to ask a question, sort of maybe hushed tones, I wouldn't be doing or using this space here for one of my patients. So I would be going into a private room. I would be shutting the door. I would be putting a sign up saying meeting in progress. So because if I'm in the middle of talking about CPR to someone or about ceilings of treatment, I don't want someone to come in and go, "Oh, Mark, have you heard the latest joke that's going around on Twitter?" And then, "Oh, sorry, you're in a video consultation." This is a workspace, and I'm using my office now for clinic purposes. And of course, people don't necessarily expect that I'm in a serious illness conversation in my office. So it's kind of, you have to just make people aware that that's the new normal. And if there's an office next door where there's lots of raucous laughter, it has happened to me, and it's great to have a team that likes a joke. But again, if you're in a serious illness conversation, it doesn't always work that well. So you might want to go out and say, "Look, guys, I'm actually phoning Mrs. So-and-so. Just be aware of the next 20, 30 minutes or so. No loud noises, please, if you can." And then, yeah, similar situation to when you guys are usually breaking bad news. So sometimes you explore a little bit how much they know already. You maybe ask an open question. You sort of say, so that they can come out with what they already know, what they already suspect as well. And I tend to always have a little bit of a plan for what to do next broadly as well. So if I say, okay, this is really bad news, I'm telling this person, like I did a few weeks ago, that their cancer has really spread and it's gone to the lungs and it's quite serious, then I'll already have scheduled an appointment for next week to follow up how they are doing. And then in the clinic, I can then say, during the clinic, and say, look, Mr. Rogers, I've got an appointment for you next week, and I'm sure lots of questions will be popping up in your mind after this that you haven't asked now. Write them down, and then we can go through them. So that follow-up is really important and really valued. I find them quite tiring, video consults and telephone consults. I don't know if some of you have found this as well, but I've found them really exhausting, and maybe seeing someone face to face actually is less taxing, less tiring, or maybe I'm just more used to it. I'm not sure what it is, but actually spending a whole morning in your office and, even going through 5 or 6 patients via video consults or telephone is really quite tiring. And I find I'm more tired than when I've seen those people in real time. And maybe that's because there's more support structures. If you've got a proper face-to-face clinic, you've got more, say, nurses or HCAs around who can help with blood taking or directing the patient to X-ray or family or thing. Whereas maybe I'm doing a lot more myself now in terms of organizing things, scans, GP review, and et cetera. So take breaks. That's really important. I know your limitations, and if it's the 6th patient and full being bad news, you should really consider whether now is the right time or whether you need a bit more of a break to be ready to go into it. So during the call, now more than ever, I suppose, to who's the other end, especially with telephone. So really introduce yourself, give a really long, detailed introduction of who you are, and check who they are. Recently with video consults, don't think that elderly people are not willing to do it. They're very happy to try. But so when I called a gentleman and his wife recently, I had a young lady on the other end who had set up the phone for them, basically, and was their niece. So that was lovely. I said, who are you? And she said, oh, I'm Mr. So-and-so's niece. And then she went to the other room and handed over the telephone. But quite interesting who you might see on the other end. Be prepared for the unexpected. And always check. I think confidentiality is of course remains incredibly important, but make sure that it's the right person. And this hasn't happened to me yet, but I'm sure it will. That you essentially from your office video phoning someone and then contacting another person. They might be in the car. They might decide, well, actually, I'm at a traffic light at the moment, so it's absolutely fine for me to pick up this call. But I would quickly switch off and say, well, I'll call you in a moment. I don't want to call you while you're driving. So make sure they're safe and make sure that someone is around when you're phoning them. Especially if you've got bad news, there might be good ways of saying, is there anyone else in the house at the moment? Lots of people over the last weeks have been self-isolating. I must say I was talking to a lot of people who'd been alone for a long time, and actually I was the first person they were speaking to. So we ended up talking about lots of other different things because I think they were just really lonely. But yes, warning shots, as they always are, very important. I always tend to preface that I've got some serious news, and everyone has their own style, but I sometimes say I've got some news that isn't so good, and I wanted to let you know about this. Then maybe a brief pause, and then I carry on and give them the information. I'm sort of a big believer in kind of checking whether they're okay to receive the news, but then to go in without too much prelude or hesitation. I mean, I've seen people try to do small talk beforehand, but your patient is usually not in the mood for this. They want to know what's going on. They want to know the result of that scan, and you need to be very clear and not use jargon, but actually get on with it and tell them what's going on. Often you find that people have already suspected this, and they say, "Oh, I knew it was this. I knew that the cancer had spread to the bones." Or, so you're sort of confirming their fears, but let them talk it through. But be very clear in the information when you're transmitting it and when you're giving it. As I said, don't use too much jargon, and even in the not uncommon situation when I'm talking to a patient who's who's been a nurse or is a doctor or a healthcare professional, you know, they're in a different zone right now. They don't want to necessarily hear all the jargon from you. You can check with them what sort of language they want to hear, but most of the time when I check, they often say, no, talk to me like you would to any other patient. I need to have this information broken down, and I can ask you follow-on questions later. Yeah, and then, you know, closing the conversations, I try to bring them back into the now and the next few days. What will you do now? Who are you going to talk to? Shall we make a plan? What should we do next? There's some important items to talk about. You don't really want to, even if it's been bad news, I think you sometimes need to sort of say, well, there's lots of things we can still do. And I think that's what good palliative care is all about. You know, they don't want to hear from someone saying, there's nothing further we can do. I'm not going to ever see you again. Go off and see, you know, the palliative care doctor or palliative care nurse. No, they want to hear that there's a proactive plan and we can do certain things. We can do things for the pain. We can help with the nausea. We can make sure that there's a someone from social work who comes to the house, or perhaps someone to help with some of the difficult financial side of things, someone from welfare rights. So there's a host of things that we can always do, even if the news has been bad. So the overall summary has to be that there's plenty we can do. There's always something we can do to make a bad situation a bit better. And I tend to get them to summarize a little bit. I don't always do this. I will admit to this. I'm sure if a few of the registrars in palliative medicine are on this who've seen me consult, they know that I don't always get the patient to summarize, but it's a very good thing to try and do, you know. So, you know, what I'd sometimes say, what have you heard today? What have you heard from me today? How would you explain this to your wife later on when she comes back, or how would you explain it? And, you know, trying to do that in a very non-patronizing way, I think is really important. And sometimes they repeat things, and you can sometimes see if they've got maybe a bit of the wrong end of the stick, or they've not quite understood something, you can really hone in on that, and you can sort of clarify a few things. I think that's a very good technique, even on a video consult or a telephone consult, to bear that in mind. And yeah, the importance of writing these conversations down helps me restart things next time I call them. You know, the big areas that have been discussed, and then repeating those a little bit. And it's incredible how I get a bit annoyed with some doctors sometimes who say, oh, but I told Mrs. So-and-so that this and this and this and this and this and this, and they'd been talking at the patient for 20 minutes. And of course, it's not surprising that the patient has forgotten about 75% of what was said, but then they insist that they've told the patient all of this. Well, you know, if I'm in a setting that I'm not aware of, if I've never been in healthcare before, I mean, this is like if I go to the garage and Gary, my mechanic, tells me what's gone on with the car. Am I going to get 95% of what he said? No, absolutely not. And if he repeats it to me, then I'm far more likely to remember it. So sometimes you need to hear things 2 or 3 times before you've fully understood it. And I still don't know what the quality of video consults or video presentations is. You know, you might be listening to me right now and you might be picking up 20% of what I'm saying. Who knows? If we were face to face with each other right now, would you be picking up 40% of what I'm saying? I've no idea. I really don't know. But don't assume that what you said has been heard or understood, and always be happy to repeat it. And in fact, my registrars will often probably think I'm a bit crazy, but I always introduce myself and reintroduce myself. Say if I'm doing a ward round, for example. So I've met a patient last Tuesday. I'm going around again this Tuesday, and I will say, my name is Dr. Mark Taubert. I'm a palliative care consultant, and these are the rest of the team members. And the patient might say, oh, I know that already, but sometimes they may have forgotten the name, and they've met so many new people that I actually don't assume that they can remember absolutely everything. And yeah, I'll kind of close down the conversation, and also sometimes express that we understand how difficult things are, and that we see this a lot, and that the fact that I've communicated this via video or telephone is a matter of great regret to me. That I think is maybe not the right forum, but in these times, sometimes it is better to have the information than not have the information. So far, everyone has said to me, no, absolutely, really grateful that we've had this, and they've been very grateful about the video consultations as well. I mean, I sense they would, of course, always prefer to have it face to face, and that's fine. But it's the best of a bad lot at the moment, and I think we may be stuck with it for a little bit longer, I'm afraid. I hope not, but I think we need to all prepare that this might be around for quite a few months longer than we had initially hoped. Okay, and so the second part of this presentation is really me having a bit of a moan about a few things and a few warning shots about the media, the general media, and what they make of things. So I had a contact with the Western Mail, actually a very nice journalist called Abby Whitewick, and she said via Twitter, she got in touch, she said, Mark, what's been some of the lessons from COVID-19? What have you noticed? What's important for palliative care? And so I kind of talked about some of the big issues, and I took her through some of the areas that I've just talked you through just now. And I sort of said, this is probably something that I would communicate to my colleagues or to my trainees, what I've noticed, and I'd maybe sort of check with them whether they've had similar experiences or not. And she said, oh, that's really interesting. I'd happily put that into the newspaper edition of the Western Mail if you want to, which she did, and that was really great. But then her colleagues in the online editorial office for Wales Online also got hold of it. And they're all sort of 20 years her junior, but they're more senior ranked apparently in the press because they know more about digital and online. So she gets very frustrated about them. So they just grab her information and basically put out headlines that are not representative. So I essentially found on Twitter that this online editor had taken Abby's article and put a headline of Dr. Stromer of awful phone calls he is constantly making to families, which of course made it sound like I was having a moan about having to have awful phone calls and video calls to families. And it made it just sound like I was kind of spilling the beans about an awful situation, and that of course it would be far better to have face-to-face consultations, but which wasn't possible at the time. So yeah, I think, you know, we sometimes fear the media, and we're sometimes worried about the media, and you know, the colleagues at Macmillan sometimes have got a lot more experience about how careful you have to be. John was nodding his head there earlier, and I'm sure you sort of had your experiences. But it can be good and bad. On the left, I think, is a good example, because I've got lots of people writing in saying, "Oh, that's really interesting," and you know, thanks for that information. That can be quite helpful. And on the right hand side, you know, you can get a sort of slightly more immature approach towards it, where it's just headline hunting and clickbait, and perhaps not necessarily what you wanted to bring across. Now, you might have heard from my accent that I'm German. I'm very sad about 40 Towers episode, the Germans being taken down, because it's one of my favorite episodes, and I think they've put it back up again as far as I can tell. But it's just interesting to see in this day and time with the media, and perhaps with some of our language as well in healthcare, how we're using a lot of war metaphors and violence metaphors. Battle against the virus. Just listen to the radio for a little while. There won't be any report nearly that you listen to about coronavirus that isn't about patients battling and fighting and using that sort of violence rhetoric. And a lot of us in this forum here know about this battle and war metaphor rhetoric from cancer, the fight against cancer, the war against cancer, and this kind of thing, which a lot of my patients and their relatives have actually found very disempowering and sort of lets them down a little bit. So I was just tickled by this article by the Daily Mail, which said, "War on coronavirus. Germans don't use World War II rhetoric to describe the pandemic response because they associate it with loss." Okay, you've mentioned it. But Britain and the US are happy to invoke the Blitz spirit. It's a very typical Daily Mail kind of article, which is incredible, but they based it on some research that they had found, and the conclusion was German coverage uses scientific language Christ, they use scientific language. How awful is that? Partly due to losing the war. Well, my argument would have been it's actually always good to use, more scientific language and to use science, not too jargonistically, but be factual when you're reporting on things. So just a real sort of kind of how our language is being shaped during coronavirus as well. And maybe don't be too tempted by the war metaphors and about fighting and battling, because in every fight or every battle there's a loser as well. And a lot of people don't like to be remembered as a loser having lost their battle. And also the BBC got in touch then and wanted something. They said one of the biggest search items on the BBC website at the moment is, how do I write a condolence card to someone who's died during COVID-19? Interesting, isn't it? Articles about helping people who've just been recently bereaved. What on earth do I say to them in this sort of situation? Because it's so awful, some of these situations where people have died alone in hospitals and the grieving have not been able to see them, and the whole funeral situation where there's only 3 or 4 people allowed at funerals, and there's all these online funerals that are happening. So people are really struggling and really scouring and searching the internet for how to help those people who have recently been bereaved. Now, Macmillan will have an interest in this, and a lot of the other charities in Wales will have a big interest in this sort of area. And I think it's perhaps something that needs to be better disseminated. And I just value some of the experiences that maybe some of the colleagues here on this in this group have had later on. Just really, I talk in this article about some of the experiences that we've had and some of the things that we've seen, and again, maybe giving some tips on how to communicate with people and perhaps not be too reticent to use the new online technology that we have. I reflect on the fact that had coronavirus happened 10 years ago, we would have been a very different situation with video. And I doubt very much that we would have been having this sort of Zoom meeting in response. Of course, nothing replaces touch, nothing replaces face-to-face and that connection. But at the very least, what we learned from Italy was the lack of laptops, the lack of tablet computers was a real regret. And we had a patient in Vilindra, and it was very nice because he was able to join in a dinner with his family via Zoom. And he found that he was absolutely blown away that he was able to do that. So we need to sweat the small stuff and sweat the video stuff as well, and the Zooms and the and all the video messages as well. Now I put forward 5 points in terms of how I prepare for these sorts of things. But if you want to delve into it more deeply, and a lot of you are trained communicators, I know that, but I kind of have to kind of up my game every few years and go on a course or read some interesting communication guidance. I've always liked Nikki Pease, my colleague. She came up with the Cardiff 6-point toolkit, and in terms of how she approaches serious illness consultations. And I think it really translates very well to online, to the video consultations and to telephone consultations as well, in terms of things like warning shots and some of the things I've discussed with you earlier as well. And any of you who are doing the diploma in palliative care with Cardiff University or the master's program will probably be aware of some of the different communication toolkits that you can use. But if any of you are doing the diploma and interested in writing some of your dissertational work on some of the phone consults or video consults that you'll have, I think Fiona Rawlinson and all of us would be very interested to read that as well. And finally, I've put up a few resources that you might find interesting in conjunction with this. So screen shares with patients and their relatives might allow for you sharing some of the videos that we've created for talkcpr.wales, where you have videos explaining why on earth someone would want to contemplate a DNA CPR form, or why that discussion might be important. We've created a really lovely advancedcareplan.org.uk website with videos and resources for healthcare professionals, and also links to the quite new advanced care planning All Wales documents that we've created with the All Advanced and Future Care Planning Group, where there is now an All Wales Advanced Decision to Refuse Treatment document, which is brand new and people probably don't know about yet, but it's there and it's bilingual. And we've got a advanced statement of wishes and preference document. We've got an RBID for Wales on there. So lots of really good resources there. E-learning for health. I got involved with them. That's a sort of England and Wales resource. And we've got something on there about telephone and video consultations and checklists on giving news of a death to a loved one, for instance. So these are some of the things that you might want to take a look at after this meeting, or in the future for your continuing professional development and your various portfolios. If you want to get in touch, I'm on Twitter at Dr. Mark Taubert. You can get in touch via email as well. These are some of the hashtags that we use, and I hope you found that useful. I don't tend to do very long consultations because I'm aware that a lot of you are sitting in front of a screen and may need a stretch. So that's all from me, and I'll stop the screen sharing. Stop share, and then we're all back in the room together. Thank you.
Thank you, Mark. It is for me, I think starting off the presentation with the mask and the rest of it really strikes home that what the face of patients is seeing as well, and our interactions with yourself as well. There's some comments and questions on the side, so I'll pick those up. So from Elise, are patients and families asking to record consults? Is this something we need to consider?
Good question. No, not yet. I wouldn't have a problem with that. Yeah, I mean, it's and in fact, I've not thought about that one yet. So good question. I'm talking to the so I'm using AccuRx at the moment, the video software which our trust has bought into. Next week, I've got a presentation with Attend Anywhere, and I'm sure I've seen a record button there. So I suspect on my end I can record. Whether they can record on their end, well, I would suspect they can probably do that anyway, because with modern technology nowadays, how are you going to prevent that? So I think it would be very difficult to prevent them from recording anything. If you as a healthcare professional have a problem with that, you might want to say, I'd rather you not record what we're saying at the start as a little disclaimer. But I think even if technologically the Attend Anywhere software wouldn't allow for the patient to record it, how are you going to stop them from recording it via their smartphone or another device? Impossible. I don't have a problem with it. I've actually had people record things in my outpatient clinic, and then they've listened to it later with the rest of the family. And actually, I've not really got anything to hide. So, you know, if I've been unclear about something or they want to ask me something, they say, "Oh, Mark, you said this and this last time around." Perfect. Yeah, that's great. You know, yeah.
And I thanks, Mark. And it's expanded on the side there. People are really interested in that point and how much people can. So Sarah's asking about how much information is retained, conversation face to face. We're living in a bit of a new world, really, don't we? We haven't got the evidence to support. We don't know what harm the recording could do.
Yeah.
So it's a real interesting point, and I don't think it's a question we would have asked a year ago, is it? I think it's the new way of working. I wonder what would have happened if we hadn't have had Zoom and the rest of it. It's something that so we've got, in my eyes, we've got version 1 of what a Skype consultation looked like.
Mm-hmm.
It'd be really interesting to capture after this is how we could improve it as well. You stipulated early on you're in a meeting room now.
Yeah,
you wouldn't use before. What does the best meeting room look like, and what is the best technology available to you?
Yeah,
and if we have to continue in these new ways, really. So some really interesting questions coming up on that side.
Yeah, and I think every new thing you do in healthcare or everywhere else has about sort of, this is just my experience. From the smallest things, sometimes there's 10 consequences that you can plan for and that you've thought about. And then there's about 5 that you would never have dreamed about and not thought about and gone, oh my word, what do we do about this? And some of them will be negative consequences. So everything you do will have negative consequences. And I always kind of find it quite funny because I sometimes use as an example in the 1960s when everyone was talking, should we get telephones onto our wards? Should we get telephones into our GP consultation rooms? And now we laugh about that, but it was a big deal then. It's like, ooh, people can listen in on anything, and what are the rules going to be, and how should we contact patients by telephone? And we're still talking about it to some degree.
Yeah. The comment about how this new way of communication, it continues through the comments box with Leslie. I've heard the difference compared with the effort a person with a hearing deficit has to expend in a normal face-to-face conversation. So, ultimately, you might be meeting patients' needs in a greater way, particularly those with hearing difficulties. So.
Oh, absolutely. I mean, that's a real issue, and I mean, so the way we've gotten through that is sometimes they have people with them who can help them as well, and interpreters or their family members. But if not, then if it's really had to be video, then we've just had to have someone else in the room who's been able to write things down and then explain it at a later time point. It's so difficult, really, really hard. And then through the medium of video or telephone, it's just, it seems impossible, but you have to try. You have to sort of try the best to kind of really break down those barriers as much as you can.
I think after this, I think there's going to be many a talk, I think, about the benefits of Skype and the rest of it. Moving on to a different subject, Mark, is Catherine have asked, first of all, she said, diolch, Mark, with the public hearing about death and dying on a daily basis, are we likely to see more people open for advanced care planning discussions, or are people fatigued by death talk?
I think there's definitely been more conversations about it. Whether the quality has been better, I'm not so sure. I mean, as I said just now, there's still a lot of the battle rhetoric, the fighting rhetoric, and that we shouldn't take things on the chin, and the spirit of the Blitz going around, and death is still a dirty word in many ways. And of course, no one wants to die of coronavirus. No one wants to die of COVID-19. And I actually, overall, when I've looked at Twitter, Facebook, I haven't seen an improvement in the rhetoric, I must say. I suppose it may be up to us to improve the conversations and jump in when the quality of the conversation is actually declining, and sort of say, hey, actually, this is something we've been talking about for years. My good colleague, Dr. Paul Keeley up in Glasgow, has written an article for the Spectator, actually, about the quality of the consultations, and needing to weigh in as palliative care people, and to sort of say, hey, hang on a moment, actually there's a few things in advanced care planning wise, future care planning wise, that we need to talk about anyway. Now is a good time to do so. His conclusion in the article was, and it's my conclusion as well, is that once lockdown is over, everyone goes back to the pub and everything goes back to normal again. So, that sounds a bit nihilistic, but, and I'm trying as much as I can, and I think a lot of you are also trying to keep up the good quality conversation. Don't feel frustrated if some bad quality conversation is gone, because the worse the conversation, the steeper the learning curve, in my view. And you get some really quite dysfunctional comments sometimes, but actually when you weigh in and they hear from maybe some of you people who've got so much more experience, then sometimes that improves the conversation. And whilst you might not convince the nutters out there and the conspiracy theorists, you may be convincing someone who's a silent listener out there on Twitter. That's always my view. There's plenty of people who read this stuff, and if they only read the stuff from the nutters and the crazy people, then that's going to be forming their opinions. Whereas if none of us actually put ourselves forward and say, actually, no, this is not what happens. Deaths aren't always bad, and often they're very good. And these are the things that we'd like to talk to people about beforehand in a non-dreary way, just in a very pragmatic way. Then that's a better quality conversation. And a lot of people go, actually, I'm more convinced by that than what Donald Trump said just now.
Can't believe we've got Donald Trump into a conversation. By the way, Mark isn't sponsored by Twitter. He mentions Twitter a lot, but I think if you do follow him, you see some fantastic stuff as well. Emily asks, Mark, first of all, thank you, Mark. That was really interesting. What do you see as any gaps in emotional support for palliative patients at the moment? where charities and other organisations might be able to help support?
So some of the gaps in terms of what where perhaps we're not reaching. I think always worth stepping up the game when it comes to bereavement and follow up for bereavement. And I know a lot of the charities are doing a huge amount of work already in terms of telephone calls, but I think for have availability and contact and dissemination of contacts, I think there's still a lot of people out there who are in isolation, who are alone, who've lost someone, and they don't know who to talk to. I really like the concept of compassionate communities and how we can all help each other. And there's some very good examples of WhatsApp neighborhood groups and various people supporting each other, but not everyone has access to those. And if we can get more people networked, and I think the charities are really have a good way into this, then people are not so alone in their grief. And I think a lot of people are grieving alone at the moment. And if it's anything to go from my street where I live at the moment, just checking that no one from my street is on this chat, a lot of people are hitting the bottle very hard, I must say. People are staying alone a lot and only going out once or twice a day. They're not seeing as many people. They've not got their usual daily interactions. So I think there's a lot of substance abuse going on at the moment. A lot of people are drowning their sorrows, and I think we're going to hear so much more when this is finished about people's experiences. So if the charities can prepare for that in their various meetings and their planning and their preparation, I think now has never been such an important time to get together, have meetings about this, and sort of how are we going to support this pragmatically on the ground. Not just not just have another meeting about it, but actually how do we actually go in and provide support numbers, disseminate them, go on WhatsApp and social media, and get people more closely together, including those who have less access to the internet and less networks. So compassionate communities, Compassionate Cymru, Macmillan, and various people, if they had a little get together in terms of how they can do maximum dissemination of support lines, support numbers, and get people networked into their local communities. That's got to have to be the way forward.
Mark, I think from the Wales Cancer Alliance side of things, I think because that's 20 organisations, I think is an important thing to raise. Really, is what is the impact of these new habits in that way. And Angie asks, is we've talked about the challenges. I think just to capture Angie's question here, is that we talk about the challenges and the new ways of working. Have patients been specifically positive about doing the remote consultations, or some actually preferred it? Or?
Yeah, I mean, they've been very positive with me. They say, it might be the novelty as well. But I've had comments like, it's lovely to see your face. And, and for them, it's a novelty of looking at the phone and doing a video consult. And for me, it's been a novelty in the last few months of doing Zoom meetings. There's a novelty to all of this. And perhaps all your learning is enhanced from the first few Zoom meetings that you've had. Whether that novelty will wear off, and then it's kind of actually, Mark, can I come and see you? I need to talk to you in person. Very much, I'm equipoised. I'm not sure. I'm not going to say video is going to take over or be better. I don't think that's necessarily the case. And as we alluded to at the start as well, there's nothing really that replaces the face-to-face, the ability to touch, the human interaction. And whether we'll miss that in the long term, I don't know. But I've gotten one of our registrars recently to do a video consultation and see what she felt about it. I think she thought it was okay, but it is a new dynamic. We need to get used to it, but it can't be 100% video consult and no face-to-face at all. It needs to still be a mixture of things. My clinic in Velindre, I see people sometimes from Monmouthshire. I sometimes see people from Powys. And of course, there's an element of sometimes they feel too tired to come and drive down. So actually a few of them, one of my Monmouth-based patients, he's been very grateful that he can just consult with me from his bedroom or from his living room, in a sense. And his partners found that very useful as well. So some really see a big advantage, and others are less sure about it. So geography and access is a big thing in this as well. Perhaps some of my Cardiff patients will prefer to come in and see me. Perhaps some of the patients who are further away with less access to transport might actually say, well, actually 100% prefer video consultations, never go back again, big mixture.
Yeah. Okay, brilliant, thank you. Question from Lowry, Bowel Cancer UK is, hi Mark, have you had cancer patients coming to you who have sadly had their treatment regimes changed due to COVID and now find themselves entering the palliative stage of their pathway? How have these patients come to terms with this?
Yes, I mean, I've seen that, and I've had those conversations as well. Difficult, really, good and bad, I think. I mean, I think there's always that worry that you may have missed out on some chemotherapy. I must say some of these people have been thinking it was maybe 4th line or even 5th line chemotherapy that they were contemplating. And sometimes I've actually said to them, look, I have had a lot of people, even pre-COVID, who would have said, no, thank you very much. That's not something I want. I want to focus on quality of life and other matters. I don't know. I think I can't speak for the sort of 1st or 2nd line interventions and SACT so much, but sometimes I'm sort of closely involved with people who go through quite late chemotherapy sometimes and quite late SACT sometimes, and I'm not always that convinced that actually their lives hasn't been shortened through having that, through the side effects and through the deterioration in quality of life. And actually sometimes I've sort of said to people, have you considered not having this? And they kind of go, oh, what do you mean? No one's talked to me about not having that. And then actually when we've had that conversation, they've actually sometimes opted out of having further cancer treatments like systemic anti-cancer treatments perhaps, or they've opted out of some of them, but they've opted for good maximum conservative treatments, good palliative care, and who knows, maybe that's actually improved their outcomes a little bit as well. But yeah, a mixed picture really of people saying, oh yeah, it was all changed and it was cancelled, but I'm now getting back in touch with my CNS again, or the secretary of the oncologist, and just to see if there's anything else now, or if there's anything further we can possibly do. And I think my oncology colleagues have been very careful and certainly in their MDT entries as well, in writing that flexibility has to be both ways. So flexibility on one side in the way that we sort of maybe they've decreased some of the output and been more cautious with some of the 3rd, 4th, 5th line treatments or whatever. But equally, once things have relaxed a little bit, or the risks haven't maybe been so high, and that they've been open for further discussions. And often these things take 2 or 3 consultations, and sometimes people change their mind in both directions as well. And I see a lot of that in palliative care, and I'm sure a lot of people are nodding their heads here that they also see a lot of that. So it goes both ways, really.
Thanks, Mark. Some points really to finish off, because I'm conscious of time, is that Joe has said that, interestingly, I think we are grieving the loss of doing things that the way we want to.
Yeah.
In my experience, patients are more accepting of it than we are. I like your point about self-care, because I suspect we need to allow ourselves to grieve the old way to help our acceptance of the new situation. So it's a point from Joe there. And then Catherine just comes in as well. Great to hear the role of compassionate communities and compassionate Cymru as an opportunity to build emotional resilience. Sure, Leslie will agree. And Leslie jumped in straight away and she said, yep.
Yeah.
So from those perspective, I think, it's the messages, I think, from everyone is just to, from that side, it's great that there's new ways of working. We might drop some of these ways of working, but we need to give everything a chance in that way. And as I'm trying to close off the meeting, other stuff is coming in unconscious. Go on, Mark.
Yeah.
I'll just go through these points. Martin has just jumped in. We've called for greater availability of e-consults to help plug recruitment gaps. Has been an evidence of being able to provide better care to more people as a result of patients not having to travel to you. So I think what Martin's saying there and others is that we've asked for this before. I think in regards to video consultation, I think is that it's the case of we've had to do this, not that we want to do this now. So it's interesting in regards to that as well. And then Jane is just to share a comment from a patient in the hospice. I know you're actively listening to me. I can see it in your eyes and from your posture. Although PPE can be such a barrier to effective communications, we are still effective communicators. And for me, I don't think there's a better comment to end on than that. I think that, you know, what you guys are doing, whether it's through your eyes, through your body language and the rest of it, I think is really, really positive. And what you're doing is you're doing your absolute best.
Yeah.
It's been
comment from one of my palliative care colleagues, Clea, as well. She said, and I don't know what she does, but she says you can communicate with your eyes a lot as well, behind PPE, you know. And I suppose that's true. I think we have different ways of, you know, expressing ourselves, and I try my hardest to be as expressive as I possibly can behind PPE.
Yeah, and you know, for me, you said it early on. You're most probably more efficient in seeing patients. But emotionally, I don't think it's as efficient in relation to the Skype. Is there? There's many people I've had Skype calls with, and the Alliance members as well. After an hour or so, you're just absolutely fatigued because you're not getting feedback from anyone. And I'm sure you found that with your presentation is because you can't engage with people in the same way. It's very, very tiring in that way. But for me, Mark, is to close this off is just to say a massive thank you for your honesty. Like I said, you have got that sense of humour, and we're really grateful. You've set the bar high for future morning seminars we're going to do. Really grateful for all the work you're doing for patients as well. Your honesty is always what comes through to me, and like I said, those small details, whether it's eye contact, whether it's the language we use, touch is so important to patients as well. And I'm sure everyone on the call will just, you know, say a massive thank you. There's a raft of thank yous coming in the comment section. But ultimately, on behalf of the Wales Cancer Alliance and all its members, I'm really grateful for you investing the time with us this morning. So thank you, Mark, and thank you for everyone for joining this morning. Hope everyone has a good day and the rest of the week.
Thank you very much, and thanks for everyone attending and coming to listen, you know, and giving me a bit of your time, and I hope it's been useful.
Grateful. Thanks, everyone.
Bye-bye.
Bye-bye.